Greeting everybody. We are talking today about upper limb technicals. We will complete the part 5. Today we are talking about very common short case, which is distal biceps tendon rupture. This is 38 years old male. He's a weightlifter. He sustained the injury to his right elbow while he is trying to prevent a fall while he is at work. He felt painful pop at his elbow and arm. The clinical pictures diagnosis is very clear. You can see here ecchymosis and swelling. Also, there is bulge in the arm, which is Boobian sign. So it is a rupture of distal biceps tendon. So usually it is a spot diagnosis. Try to describe the picture very quickly and say the diagnosis directly. If you want to say differential diagnosis, but the first one in differential diagnosis should be the spot diagnosis. This is another clinical picture. If you want to take history from this patient, you will ask about prodromal pain at the anterior elbow, which is tendinitis, as a cause of the rupture with minimal trauma. Patient, you will ask about painful pop sensation, anterior elbow pain, and weakness of supination. Yeah, how you are asking what weakness of supination? Is there is any limitation of opening a jar or manual use of screwdriver? And elbow flexion, if he has limitation of or weakness of elbow flexion with lifting his back or something else. For signs, the main signs here are ecchymosis and swelling about the elbow, and the bulge, which is Boobian sign. For palpation, usually we are using hook test. While you are flexing the elbow 90 degrees at the side of body of the patient, you are examining the integrity of biceps tendon by hooking it from lateral to medial. You can feel something rigid, like lacertus fibrosis, which is responsible for false negative hook test. Lacertus fibrosis, if it is still intact, it is responsible for lack of retraction of biceps tendon, which is beneficial for its management, as you will see. Also, it's important to examine neurovascular examination, peripheral nerves, ulnar nerve, medial nerve, radial nerve, even by screening movement, as we discussed earlier. Also, you can ask about sensation, especially sensation at lateral side of forearm, which is supplied by lateral cutaneous nerve of forearm, which is directly related to biceps tendon. At this stage, he can ask you about the anatomy of biceps tendon. Biceps muscle is mainly supinator, so loss of its function results in weakness of supination by 40% and weakness of flexion by 20%. This information is very important. Distal biceps tendon is inserted into bicipital tuberosity or radial tuberosity at the ulnar aspect. The role of radiology, X-ray, it is a routine. Ultrasound, it can diagnose the tear, but it is operator dependent, but it is cheap and accessible. But the MRI is the gold standard because it can diagnose the complete tear, and also it can diagnose how much it is retracted. So it is good for planning of the surgery. The discussion will be, what about if presented by complete tear, but it is neglected for late presentation? What he will tell the patient, what he will lose, he will use 40% of forearm supination and 20% of elbow flexion. But if the complete, how you are planning management, we have two categories of the patient. If the patient is young and active and he want to uh, doesn't want to lose the power of his supination and flexion, so we will offer him surgical treatment. But we, we will do direct repair if the patient presented early before 4 weeks. But also we can do primary repair even after 4 weeks up to 3 months if lacertus fibrosis is intact, which prevent great retraction of the tendon. But in case of delayed presentation or neglected chronic tendon rupture, the distal biceps usually require reconstructive surgery because neglected chronic case, it will be associated with atrophy of biceps muscle, plus it will have fatty infiltration. This is algorithm for management of distal biceps rupture. Here, the rupture can be partial or complete. If it is partial by MRI, to more than 50% rupture, and it is acute, we will do direct repair, acute less than 4 weeks. If it is more than 50% rupture, partial, and chronic rupture more than 4 weeks, so first surgical repair attempted usually with autograft reconstruction as augmentation. If the patient has partial rupture, less than 50% rupture, we will try conservative treatment. But if the patient has complete rupture with positive hook test and confirmed with MRI, and the patient has sedentary life with low demand, and he is willing to accept limitation, which is weakness of supination and elbow flexion, we will try conservative treatment. But if the patient has complete rupture, is young, active, manual labor, or elite athlete, we will offer him surgical repair. In this case, we have two categories. Acute rupture less than 4 weeks, we'll do primary repair. If the patient presented late more than 4 weeks, sorry, this is more than 4 weeks, we will do try primary repair, or we will do reconstruction with autograft. This is lacertus fibrosis, which is responsible for maintaining the length of the tendon and prevent great retraction. What is lacertus fibrosis? It's a fascial thickening that connects distal biceps tendon superolaterally to the fascia over the forearm flexor muscles in the inferior-medial direction. Anatomical continuity of lacertus fibrosis prevents retraction of the torn distal biceps tendon, whereas complete transection of lacertus fibrosis would lead to significant retraction of the torn tendon. Usually distal biceps tendon rupture in acute rupture, usually it is a short case, and but very difficult to get this case as a real patient. But if a real patient, it will be chronic neglected rupture in an elderly patient that has been treated conservatively. and in you are expecting to find weak supination and weak flexion, and also atrophy of the muscle, plus bovine sign. In case of surgical repair, uh, discussion could be about the approach and the technique of the repair. We have two methods of repair, one or two incision repair. One incision, it is a modified Henry approach, make incision over the anterior aspect of the elbow, located over the ruptured distal bicep tendon. You are retrieving the tendon by milking or direct visualization, and retrieving the tendon and taking suture in the tendon by any method like Krakow or something else. Insert the bone suture anchor into the radial tuberosity and reattach the tendon. So you can fix by bone anchor, or you can use mica tunnel and use endobutton fixation coupled with unicortical interference screw. So combined suspension and interference screw. This is one incision method. The benefit of this, when it is only one incision, but its drawback, it can cause, you can more easily to injure the posterior interosseous nerve. Two incision technique, Boyd and Anderson. We are making 3 centimeter transverse incision over the distal biceps and insert core tendon suture through the end of the tendon. And the second incision, posterolateral aspect of the elbow behind radial tuberosity. We are locating the tunnel beneath the radius and between the radius and ulna, through which tendon originally passed. Make a drill hole through the radial tuberosity to allow anchoring of the tendon. Retrieve the biceps through the distal incision and pass sutures through the radial tuberosity drill holes and tie them down. This is more secure and more powerful fixation. It is a very important question. What are the complications? The most common complication is injury to the lateral antebrachial cutaneous nerve. It is most commonly observed with limited anterior approach and extensile anterior approach due to superficial branch of radial nerve also. Another complication is synostosis between proximal radius and ulna with double incision. The most dangerous complication is heterotopic ossification, is most commonly reported from double incision. Heterotopic ossification, this is very important, especially if the patient neglected case or presented late. After surgical repair, especially early repair, the patient is able to return to work between 3 and 4 months. Also, the nerve injury here, the sensory nerve injury, usually it is a neuropraxia, and it will resolve spontaneously. This is another case. This is a patient. He can present this only clinical picture or present both the X-ray and the clinical picture. Can you see here? The patient is asked to extend the thumb, but for the right side, he is unable to extend his thumb. On the left side, he can. For the X-ray, the patient, he is a skeletally mature patient, and he had undisplaced fracture distal end of radius and managed conservatively in the form of below elbow cast. And he removed the cast after the injury by 6 weeks. And at 10 weeks, meaning 4 weeks after removal of the cast, he suddenly discovered his inability to extend the right thumb. What is your spot diagnosis? My spot diagnosis is rupture of extensor pollicis longus tendon. So there is rupture of extensor pollicis tendon, which is confirmed clinically, and the radiograph showed will heal distal end radius fracture. For the patient, how to complete the examination? We will complete the examination by inspection, seeing that there is mild swelling, there is no scars, no atrophy of muscles, and for palpation, we will palpate the distal end radius to see there is healing or not. And then we are going to examine the tendons. We will examine all the tendons, extensor and flexors of the hand, ulnar deviation, radial deviation, um, the small muscles of the hand, as explained earlier. Also, we will use a screening test for nerve injury. We are using like making screening movement of the nerve injury. We will ask the patient to do extension of thumb. Yes, he's unable. We will ask him to do extension of wrist metacarpophalangeal joint. So we are expecting radial nerve is intact, but this is a tendon injury. We'll ask the patient to cross the finger as a screening movement of ulnar nerve, and ask the patient to make OK sign as screening movement of median nerve. Then we will ask the patient to do some test for tendon injury. We'll start by screening movement. We'll ask the patient to make a fist and release it, and making abduction of the finger, adduction of the finger, and then we will take the movement of thumb in details. Ask the patient to bend his interphalangeal joint against resistance to see the power. Ask the patient for thumb flexion, thumb adduction, all of these against resistance. Opponents of the finger of the thumb, and for flexion of flexor digitorum of the four fingers, and flexor digitorum profundus and flexor digitorum superficialis. Also the extensor to examine the extensor indicis proprius and extensor digiti minimi, and also extensor digital communis. We will examine, the case is not just examination of extensor pollicis longus, but it is also to test your ability to differentiate between the nerve injury and tendon injury. So it is very easy case, and you can get full mark very easily. After you say the diagnosis, it is only isolated extensor pollicis longus rupture as a delayed complication of conservative treatment of distal end radius fracture due to attrition or incorporation of the tendon itself inside the callus. It is attrition injury. So it is not traumatic injury, so primary repair is not possible. So what you are uh, what you are going to do for this patient primary repair is not possible. Why? Because it is like a chronic injury, not traumatic. So the edges will be degenerated because of chronic attrition. So it is acute on top of chronic. So for this patient, we will do surgical exploration, which can reveal proximal uh, portion of extensor pollicis longus, which is significantly attenuated and frayed up, so it can't be repaired primarily at the musculotendinous junction. So I will offer him tendon transfer using extensor indicis proprius. So it is important to examine the extensor indicis proprius integrity. How many incision you will use? This is a very common question. So the exploration, we will do full examination of the bone itself. There is no bony irregularity, no bony spicule, no prominent Leicester tubercle evident at time of tendon transfer. So, because what causes the rupture? It can cause a rupture of the graft also. We will do the repair and do cast for the patient for 6 weeks, then starting occupational therapy for the hand. Sorry, how many incision? We can do 3 incision, as you can see here. 1 incision to retrieve the extensor indicis tendon at the metacarpophalangeal joint to the index finger. As you can see here, this is extensor indicis proprius, and another incision here to retrieve the proximal part of extensor pollicis longus at musculotendinous junction, and a third incision over the dorsal aspect of the thumb to reattach the extensor indicis tendon to the distal phalanx of the thumb. So 3 incision technique. It is very easy question, and also the questions are easy. So it is very easy to get the full mark in this question. And it's also common. Another case, you can see this clinical picture. What you can see in this picture, the patient is bending the elbow. He's bending both elbow, but the right elbow, he can flex up to 130 degrees, but this elbow is up to 90 degrees. And when he is trying to extend the left elbow, there is extensor lag about 30 degrees. So what is the range of motion of left elbow? It is from 30 to 90 degrees. Also his X-ray. X-ray can be in a later stage of the exam. So the exam can start by the clinical picture. But to make the listener to this lecture uh, more oriented about the case, this is a case of stiff elbow. Okay, for stiff elbow, how you are going to take history from the patient? To get a proper history, you should know that what is the causes, what are the causes of stiff elbow. The stiff elbow can be divided broadly into both traumatic or non-traumatic or atraumatic or congenital. So these are 3 types. The traumatic It is following trauma. For example, if the patient has a radial head fracture, for example, or supracondylar fracture, or fracture of cranium, and the patient treated, for example, conservatively with long period of immobilization and bad physical therapy, so he will experience uh, stiff elbow. So in your history, you will ask the patient, when you are asking the patient about the cause, we will ask about is there is no any history of trauma? If yes, what type of trauma? Uh, what's the fracture you are diagnosed with? What type of treatment you've received? How long do you get immobilization of the elbow? What type of immobilization? Did you receive physical therapy after immobilization? This is important if the history is if traumatic. If no trauma, you will ask the patient about any congenital abnormality when this problem started. Is this problem is progressive or stationary? Um, what treatment you did for this elbow? Did you receive any immobilization? Did you receive any injection in the elbow? Do you have any rheumatic arthritis or rheumatic diseases? Um, Plus, you will ask about functional restriction or functional limitation of the patient daily activities. What is your job? Are you right-handed or left-handed? What type of your work? You are a manual worker or sedentary life, or you are physically active, for example. Um, Also, you will ask about if there is any limitation in using his hand. Are you able to dress yourself, eat by yourself, brush your teeth, wash your hands, wash your perineum? These are all you will ask about as you see in dash score. These questions are should be asked in all upper extremity clinical uh, cases. You will ask about also the nerve injury. Is there is any weakness of hand grip? Do you have any problem with writing by the hand, with carrying object, with turning the key, with opening the jars? Do you have any deficit or lack of sensation in the area of the forearm or the hand? Also, this stiff elbow may be secondary to nerve injury. For example, atraumatic cases it can be caused by inflammatory arthritis in the form of gouty arthritis, rheumatoid arthritis, psoriatic arthritis, or a post old trauma like coronoid or olecranon radial head fracture. So again, you will ask about age, uh, hand dominance, occupation, because some activities in labor, what is the importance of asking about occupation? Because in some manual workers require full elbow extension, and hence, so we will not talk about functional range of motion. Even 10 degrees of loss of terminal extension of the elbow is disabling for him. But if the patient is said has sedentary life, no lack of extension for 10 degrees is not a big deal. You will ask about onset, duration, character, progression of symptoms. And if the patient said there is history of trauma, you will ask about exact injury and its mechanism and the type of fracture or instability and subsequent treatment. One of the most common cases in the exam are stiff elbow secondary to terrible triad injury managed conservatively or missed. If the patient has history of fracture immobilization or fracture fixation, better to ask for all hospital notes to determine the previous surgical exposures, if there is nerve transposition, metal work used for, and any complication. And also we should ask about infection. You will ask about also the risk factors of stiffness after trauma. What is the length of immobilization, associated fracture with dislocation, intra-articular derangement, delayed surgical treatment, associated head injury, because the patient may complain of heterotopic ossification or myositis ossificans as a cause of elbow stiffness because of head injury or admission to ICU. Also, heterotopic ossification, you should think about what is his functional limitation. We said a few minutes before, and what is his interest and his expectation. What is the expectation of the patient? Is the patient is able to modify his activity or modify his work or change his work or not? Okay, so we will move to inspection examination. We will start by look, feel, move. Look, we will ask the patient to flex his elbow actively like this, to see the back of the elbow and to see also screening movement uh, for the motion of the elbow. And so we can see the back of the elbow and back of forearm and back of arm, and ask the patient to extend the both elbow as a screen movement of the motion, and also to see for any deformity of the elbow, cubitus varus, cubitus valgus, for muscle atrophy, for scars of previous surgery, for sinuses, for previous infection, and so on. Then we will start to do combine motion and feeling. So we ask the patient again to measure the elbow range of motion by geniometer. What is the range of motion of elbow actively and passively? Maybe active is equal to the passive, so it is a hard end point, and because the character of endpoint is very important, because if the patient endpoint of stiffness is soft, so you can increase the range passively more than the active. So the endpoint is soft, so this stiffness is due to soft tissue contraction, so it can be managed by physical therapy. But if the patient has firm endpoint, it is a bony block, so it needs surgical correction. Also, we will examine the rotation of the forearm, supination and pronation, by asking the patient to hold a pen in his hand and comparing both sides for pronation and supination range of motion. The typical post-traumatic elbow stiffness is painless, but pain at mid-range of motion suggests intrinsic component, means maybe there is osteoarthritis inside the elbow joint itself. If the patient has pain at extremes of motion, it is suggesting impingement due to osteophyte, especially in coronoid process of or distal end of humerus. This is usually due to osteophytes. So if the patient has pain at mid-range of motion of the elbow, it suggests intrinsic component of osteoarthritis inside the elbow joint. And if the patient has pain and extremes of elbow flexion and extension, suggest osteophytes causing impingement. We can ask about also the stability of the elbow, medial stability and lateral stability and posterolateral rotatory stability um, by using varus and valgus stress test at flexion of 30 degrees. Why at 30 degrees? To unlock the ulnohumeral joint. Also, you can better also to test the stability, but while the patient is doing external rotation of the shoulder and doing stress test of the elbow while patient is holding his arm above the head. And also the patient can do a push-up test for posterolateral rotatory instability. These tests are important if there is history of a triple triad or instability. Also, you should take your time in the history to ask about infection and for examination to ask about to see research about possible sinuses and possible infection if the patient had open-reduction internal fixation before. Also for palpation, you can palpate the ulnar nerve and rolling it and examining the ulnar nerve for subluxation behind the medial epicondyle and check if there is transposition of the ulnar nerve, if there is any intervention before. You can, then after examining the elbow, you can examine the neurovascular examination, check the distal pulsation, and check the nerve injury by screening it for ulnar nerve, median nerve, and radial nerve, and examine posterior interosseous, superficial radial nerve, and sensory examination, and so on. Also, we should examine the power of the muscles of flexors of the elbow and extensor triceps, extensor of the elbow, pronation, supination, and so on. This is only if the case is long, but if the case is short, you should do one test for each, and better to use screening movement for examination, which is a short case. For discussion of the case, the functional range of motion of the elbow is from 30 degrees and to 130 degrees, flexion extension, and 50 degrees pronation supination. This functional range of motion is necessary for to perform 90% of normal daily activities. But we said before that this is not for laborer or labor worker or manual worker. Loss of 50 degrees in the arc of motion causes up to 80 degrees loss of function. So if the patient lose 50 degrees of this functional range of motion, which is 100, means if the patient has range of motion, for example, from 50 to 100, if the patient range of motion is 50 degrees extension to 100 elbow flexion, so he lost 50% of functional range of motion, he will lose about 80% of the function of the elbow. This is another case, 30 years old patient presented to orthopedic outpatient clinic with complaint of not able to do his daily activities and unable to bend his elbow following trauma, which he had suffered 3 months back. The patient gives history of injury to the elbow, following which he developed pain, swelling, and was not able to move his elbow. Uh, I, I will complete the history. The patient um, has history of injury to the elbow. The patient, after 25 days of negligence, took treatment like compression bandage and massage for 1 month. He sought medical advice after injury by 25 days, and he get immobilization for 1 month. Following that, he's allowed to move his elbow. And I will ask about limitation of daily activities like dressing himself, brushing teeth, writing, carrying object, bag, and his neurological symptoms like numbness or weakness. I will examine the patient. I will measure his range of motion, elbow flexion and extension, forearm pronation and supination, uh, and the palpation for osteophytes, for tenderness, and examining for instability of the elbow, medial, lateral, lateral, and posteromedial. We will do varus valgus stress test and neurovascular assessment of the patient, especially ulnar nerve. And we will assess for 3-point bony relationship of the elbow because the patient may have missed elbow dislocation or terrible triad or um, malunited fracture or non-united fracture, for example. Then I will ask for radiology of the patient, plain X-ray on your right hand, AB and lateral radiograph of left elbow showing missed or neglected radial head fracture. I think it is not fully healed and malunited with coronoid fracture, but there is no evidence of heterotopic calcification anteriorly and posteriorly. So mostly this was missed terrible triad injury. So what you will do next, I will do CT scan. CT scan confirmed the diagnosis. So what is your diagnosis now? So this is a case of stiffness of left elbow in a skeletally mature patient as a sequelae of neglected terrible triad injury of the elbow. He can ask you what is terrible triad. Terrible triad remain one of the complicated fracture dislocation that need to be managed with utmost care and managed very early. But if the complication of post-traumatic stiffness of the elbow occurs, so we manage the case as post-traumatic stiffness following fracture dislocation of the elbow by open arthrolysis with prophylactic ulnar nerve decompression, along with physiotherapy, including dynamic splinting with hinge elbow bracing. This combination of management should be considered all because open arthrolysis with prophylactic ulnar nerve decompression with physiotherapy, dynamic splinting, and hinged elbow bracing, because for sure this is a painful, stiff elbow. When you do arthrolysis, it will result in uh, painful, unstable elbow. How to balance this? So we will apply hinged elbow, hinged elbow brace, or external fixator. We can put hinged external fixator to maintain stability of the elbow um, with repair of lateral ulnar collateral ligament, for example, and repairing the anterior capsule of elbow joint. Try to refix the head of radius, or replace it. Better to replace it and to fix the anterior chronoid. This is some tips about stiff elbow in general. If you face a case of stiffness of elbow um, as a sequelae of elbow immobilization due to fracture head radius is undisplaced. This is a simple case, so the case is only stiffness. If the patient is presented within 6 months uh, of the injury, so we can manage this case by physical therapy or dynamic splinting. So there is time and there is a rule to manage this case non-operatively. How? By serial bracing, dynamic or static splinting. Dynamic splinting is based on creep, an increase in length with application of constant load, like the principles of Bonsetti technique for treatment of Talibas virus. This in case of the patient presented in the first 4 to 6 months, because the stiffness is still soft. And also, if the stiffness has soft endpoint, we can try uh, dynamic and static splinting to improve the flexion and extension. But if the patient presented, yeah, presented with late after 6 months with elbow stiffness, or there is hard endpoint for the stiffness, or after failure of non-operative treatment, we can do surgical treatment by examination under anesthesia, along with gentle manipulation by take care for causing iatrogenic fracture, followed by splinting, or to do arthrolysis for the patient, either arthroscopy or uh, open technique. The investigation we can do for the patient can do X-rays, scan. We can search for loose bodies, for osteophytes. We can do MRI. MRI is very helpful to assess the soft tissue and assess the cartilage if there is osteoarthritis, early osteoarthritis, or if the patient has um, interarticular loose bodies, especially if cartilaginous. And also, you should rule out infection by inflammatory markers and MRI. And if there is suspicion for that, you should do aspiration. You can do nerve conduction study only in case if you find clinically nerve injury or weakness, or for medical legal. Uh, uh, these are examples for questions in FRCS. Uh, what is after is presenting the case, taking a history examination, asking what is your diagnosis. The patient has no history of trauma to the elbow. The patient is fit and well, and he is a hard-working plumber all his life. And there is loose bodies inside the elbow joint, and the patient has osteoarthritis. You will look at his X-ray. There is multiple osteophytes at medial aspect of olecranon and olecranon fossa, with a loose body just above the olecranon posteriorly. What you will do for the patient? Yes, I can do arthroscopic removal of loose body and osteocapsular release, usually the anterior capsule, with dynamic splinting and aggressive physical therapy. But don't forget to tell this need multidisciplinary approach with between arthroscopic, good, well, professional elbow arthroscopy surgeon and good physical therapist and occupational therapist. Open procedures such as outer bridge and Kashwagi procedure allow removal of loose bodies and the excision of osteophytes. For consenting the patient in these cases, you will consent the patient that there is possibility of recurrence, there is possibility of heterotopic ossification. Also, there is possibility of neurovascular damage, especially with arthroscopic intervention. I will stop now and thank you for listening to this lecture, and I will see you in another lecture for upper limb. We didn't reach end until now. See you later, and thank you.